monthly meeting that we've been holding for close to 2.5 years now, and it's a great way to get everybody at a state level on the line to talk about best practices in everything from implementation to engagement. And we hear from important folks at the state level. When they can chime in, they are very busy, so we are very respectful of their time. So that being said, I'd like to see if, since no one, actually Rayanne is on the line. So Rayanne, if you want to, I unmuted you, but if I sent you your audio pin, I'd like to have you just hop on and say hi to the group and provide an update for us. I know I received a question from Andrew Solomon of the Northeast Telehealth Resource Center about a June Medicaid update, or if that was being left up to statute. And I know we didn't have a meeting last month, so any updates you can provide from your office would be wonderful. So we'll just give her a minute to dial in if she can.
Just double checking with you, Rand, and you muted yourself on your end. Looks like you're open on the webinar there.
I'm sorry, was that directed to me? This is Rayanne Aguilera.
Hi, Rayanne. Yeah. We can hear you.
Rand, did you miss
okay,
I just hoping that you would do kind of an introduction to the group and give us an update from your perspective?
Oh, I'm sorry. I just got on the audio, so I didn't hear anything when I signed in.
No problem.
Oh,
so,
my apologies. So, Rayanne, what we were looking to hear from you about was we received a question from the Northeast Telehealth Resource Center about a potential June Medicaid update, or if that would be left up to statute. I know at the last Learning Collaborative you provided an update about providers and their location, practicing out of their homes potentially. So if you could expand upon that for anybody who may have missed that, and if there's going to be any updates in the future from your office.
Sure, I can speak to that a bit. I don't know if Joan Seacard or anyone from the Medicaid program is on.
I don't see Joan on the line.
Okay. Okay. Her office is the one that has been working on the most recent Medicaid update that would provide some updated telemedicine, telehealth-related billing guidance. Now that the approval has been received from CMS, the state plan amendments to for reimbursement for store and forward and remote patient monitoring, they are working on a Medicaid update. I have not yet heard when it's going to be out. I know it was being circulated for approvals probably the last time we spoke, and I have not heard anything else yet about it being finalized and when it's going to be published. I do know there was some talk about maybe making it a little bit more of a robust telemedicine-specific Medicaid update. They do have the option to do that. So I think they were weighing their options of whether to get this other guidance out quickly or to add some more things to it. And I apologize, I don't have the latest information from Joan on that update, but hopefully we'll be able to get something from her soon.
Wonderful. Thank you for that update, and I'm sure, you know, as that information comes out, you'll certainly let Corey and I know any updates from you, so thank you.
Sure. The only other update I wanted to give from the health department is just about the Project ECHO awards. We are waiting for approval to be able to announce those awards. So again, we hope that is information we'll be able to share shortly. The entities that will be awarded to implement new Project ECHO hubs across the state.
Excellent. Very exciting. Thank you so much for that update.
Mm-hmm.
And moving down the agenda, if there's an update from OMH, I do see Amy Smith is on the line. So I have sent her an audio pin, so we'll give her a minute to dial in and provide us with any updates from the Office of Mental Health.
Hi, Katie. I think I might be on. Can you guys hear me okay?
Yes.
Okay, great. Yeah, so we just wanted to provide everybody with an update. A couple of weeks ago, we released just some guidance regarding the ability for providers to contract with telehealth, telemedicine, telepsychiatry companies to kind of contract out with a doctor for services. So we're hoping that that will help with some of the shortages in a lot of the regions within the state. Again, it's not a regulation change, it's just guidance. And Katie, I'm not sure if that's something you can forward on to all of the members. I know I had sent a copy of that guidance to you.
Yes, and I will certainly forward that on to everybody. I did see that last week, and that is certainly exciting and very helpful. We're all no stranger to the fact that provider shortages are a reality and probably our biggest challenge. So any assistance in this regard from organizations at the state level is certainly helpful. So I appreciate that, and we'll forward that on.
Great, thanks. And we're hoping to have it posted, on the OMH site shortly. We're just having a little bit of problem getting it kind of set up onto the site. But if there's any questions, people can certainly, reach out to me, send me an email, whatever's easiest, and I can try to, answer the question or at least point them in the right direction.
Wonderful, thank you. I will send that guidance out to the group. Thank you for that update. I don't see anyone from Oasis on the line, so we'll probably skip over an update from them. Last I knew from Oasis, they were revisiting their telehealth regulations, and the governor was working on getting those created and changed and updated, so there wasn't anything on their website last I checked. So hopefully we'll hear from them in the coming months so that Article 32 clinics can also take advantage of using telemedicine. Next up, we have a presentation from Richard Curry, who is from Health Recovery Solutions. Corey, if you could somehow make him a presenter so that he can share his screen, that would be wonderful. I'll give you a brief introduction to Richard while we get him set up. Health Recovery Solutions, for those of you who don't know, is yes.
Oh, I'm sorry. Just before we do the transition to the presentation, I did see a question on here from Al Feldman, if I'm pronouncing that right. And the question is there any guidance for primary care to be provided to an OMH site for medical telehealth services?
Okay, Amy, that would be you. I think you might need to dial your audio pin again to be heard.
All right, let me see. You got me now?
Yes.
Okay, I think that might be something that's going to be a joint DOH and OMH, because it sounds like what we're saying is the client will be sitting at the OMH site, or no? Can we just clarify that?
It looks like to be provided to an OMH site, primary care to an OMH site.
Oh, yeah, that's actually...
Sorry. The question comes from Lowell Feldman, so I'm going to unmute his line and send him an audio pin so that there can be a dialogue on that.
Okay, hi, thank you very much. It's Lowell here. Yes, the question is, we've been working with some potential clients who are very interested in having primary care, for care integration is provided by medical there's two outpatient and then Office of Mental Health sites. So it's basically the reverse, but I'm wondering if there's any guideline on that yet. as we're waiting to see the guidelines on the OMH revision?
There certainly isn't. I mean, we haven't, from the OMH perspective, we've not encountered anything where they're trying to get primary care in versus telehealth into an Article 31 site. I don't know if Rayanne would have anything to add to that, since it's DOH and Article 28, that would be the hub site. Yeah, we have had a lot of guidance. Yeah. We've had a lot of inquiries, but we haven't released any guidance as of yet, so that's something we still are working on. Yeah, I think it might be something for, we haven't had them in a little while, but maybe for our bi-weekly calls that we have with the 4 agencies, just to see how that would look. And it's not something that we've had any request for from an Article 31 site provider directly to us here at OMH.
Okay, so if possible, if I can suggest, if I to you basically a proposal or an outline of what we've been discussing with OMH site, as well as the medical provider. The medical provider is would be out of an FQHC, so basically be a FQHC providing primary care and possibly some dental to the clients at the OMH outpatient program. So, who would we send that, say, draft outline to, just what the program would look like?
If you could send that to the Department of Health, we have an email address called telehealth@health.ny.gov. So if you'd like to write up the scenario that you're looking to implement, and then we'll bring it to our internal meetings with the with OMH and work on any guidance for that.
Okay, and that was telehealth. Repeat that again.
Health. The end of it is @health.ny.gov.
Okay, thank you very much.
We'll send that out to everybody in the follow-up to the meeting.
Thank you.
Okay, I don't believe there are any other questions, although, correct me if I'm wrong.
Nope, I don't see any.
Okay, I've made Rich a presenter. So to get back to Health Recovery Solutions, we chose Rich to present today because through Adirondack Medical Center in Saranac Lake, Health Recovery Solutions is, alongside Adirondack Medical, deploying remote patient monitoring units through home care agencies and public health departments in the North Country. Currently, there's a little over 100 units out in the field, and Richard can correct me if I am wrong on that number. But I thought it would be beneficial for the group to hear a little bit more about remote patient monitoring from an evidence-based outcome perspective and results perspective. The remote patient monitoring is certainly near and dear to my heart because it ties into the district initiative that we are all too familiar with in reducing avoidable hospital admissions. So I'll turn it over to Rich now to talk a little bit more about Health Recovery Solutions and some of the work that's being done in the remote patient monitoring field.
Great, thanks, Katie. So hi, everybody. Yeah, I'm Rich Curry. I'm the VP of Business Development for HRS, or Health Recovery Solutions. And yeah, we have gotten started with Adirondack Health, and I believe the Hamilton, Franklin, and Essex home health agencies are currently using at least one monitor each, I believe. We have, they had, through the grant that they received, they have about 150 units. And the interesting part is that we've been, in conjunction with Adirondack Health, just basically figuring out different ways of getting those units or tablets out. And it's been just been really cool because Bonnie has been very instrumental in just approaching everybody, and there's been a lot of interest in using us in different ways and forums, and we'll kind of get into it in a second. But going back to what Katie was saying, I think the purpose for us, or at least from my side today, is to kind of discuss what the results that we've gotten, and these are published results Some are press releases that were done internally by the agencies or companies that we work with. And you know, the company itself has been around. We just celebrated our 5th year anniversary about 3 years ago, and it started at Johns Hopkins at that point, and primarily worked with hospitals and ACOs, and really started to focus on home health, just because that's where, you know, as far as telehealth, you know, and remote monitoring, that home health has been at least 30 years into using it, and really where most of the evidence-based practice does come from really does tend to still be focused around home health taking the lead on that. So currently we're at about 60 home health agencies and hospitals throughout the U.S. When we first started, the first published study that we had done, and you know, guys, at any point, obviously, feel free to kind of you know, let me, you know, interrupt with any questions or anything that comes up. But when we first started, as I mentioned, a lot of hospitals and ACOs were targeting us, and innovation teams from there, and Hackensack University Medical in New Jersey was one of them. And that's a top 10 hospital in the U.S. And they had published this study that was, I have a little trouble. Let me just see if I can undock that. Well, I'll come down here. So that this published study was done in 2014, and it showed a 71% decrease in CHF readmissions for patients that were on the platform. So that was, again, independently done by them, and they compared it to a control group that they had internally. So I can always forward any of this information as needed to you guys. After that, Penn Medicine or UPenn, we've been with them for about 3.5 years at this point. This was some preliminary data that was used in the study that I'll go over, but this showed in April 2015 that they decreased their CHF readmissions from 8 to 3.8 visits for 130 patients, so 53% decrease. So this is just going to kind of give us a timeline of some of the results that we've gotten. First Health of the Carolinas, which was actually our second, I believe, home health agency that we partnered with. They've done a great job, and they've released, we're going to be working on our third release of information, but in November 2005, that they showed that they decreased nursing visits for home health agencies from 8 to 4.8 visits per cert period for CHF patients. So they did that primarily through video conferencing. You know, it was, they are using remote monitoring, but they were focusing on, you know, using the video conferencing to really help the nurses in the field with, you know, kind of better utilizing the visits. So a significant decrease in nursing visits, but also, let me see if I can pull it up here, that same press release that they put out, so that's where that shows that decrease. I'm having a little trouble. Oh, there we go. It also showed a 53% decrease in readmissions, I believe, also in that press release that they did. I'm just trying to find where that was. But again, I can forward these links and this information to you as well. Maine Health, which was formerly the VNA of Southern Maine, now part of Maine Health Care at Home, or Maine Health System. They, in March of 2016, showed a 75% reduction in their 30-day readmission for close to 500 patients. So this was for a year's worth of patients that they looked at and went back and looked at the information, and this was the press release that they had that was in the Wall Street Journal's Market Watch. So again, you know, a significant amount of patients, a year's worth of data, and quite a dramatic decrease in overall 30-day readmissions. And just to, I guess, you know, reiterate that they're using our system for remote patient monitoring. In most of these cases, they're also doing video conferencing. I'll specify when they're not, but in let me look here. Cornerstone does actually all of these cases except Catholic Health. It was all, they were all using video conferencing. So Penn Medicine, again, UPenn. This was a study that they had released April last year, and this showed for this was 3 years worth of data, and in that 3-year period, again done independently, they showed a 73% reduction in all-cause 30-day readmission rates in that 3-year period, using our tablet-based monitors. So again, significant numbers. We're not talking about just, you know, a small sample size or a small amount of time for the remote patient monitoring results. Catholic Health in December of last year, they showed a 6% 30-day readmission rate for their CHF patient. But what was interesting was they, and we've been getting a lot of good best practice information from some of our current partners that we've been doing some telehealth conference calls with, and just really trying to figure out how are these guys really, how are their telehealth nurses really using the system, and how are they getting these numbers. And Catholic Health in particular has really great adherence numbers. So again, the 6% readmission rate for those CHF patients, but they had gotten their daily adherence for taking their biometrics to 90% during this press release, but now it's over 90%. And their daily, taking the daily symptom questionnaire through the software was 82% daily adherence rate for those CHF patients. And that's a significant number, based on what we've found from other agencies. That's really the hardest thing to get patients to do a lot of times, is to get them to actually answer these daily symptom questionnaires every single day. And just as a best practice kind of thing that we definitely promote now, there's a text messaging feature on our software, and they basically, after 1 o'clock, they said, hey, if anyone hasn't taken their daily symptom questionnaire, we'll send them a text and tell them to do it. And a lot of times the patients don't answer, but they do it. And so now their adherence rate on the last quarter for this was actually over 90%. And it's just a simple thing as far as communication and using remote patient monitoring to, as well as additional communication features to reach out to these patients and be able to say, look, we need to know what your symptoms are like today, and that's why this system is in your home. And it's just another way that, again, best practice information that we've gotten, and we definitely pass on to all of the clients that we have. First Health of the Carolinas, again, so this was another press release they did this year in January, and it showed that with their readmission for 220 high-risk patients, they, with the reductions in readmissions from September of 2015 to May of 2016, they saved almost $2 million for the payers that were involved in the remote patient monitoring. So that was this press release. Well, this is a story that kind of talks about it. It goes a little bit into detail about the payers. It wasn't all Medicare. There's some private insurers, but the bottom line is they saved close to $2 million in readmissions based on preventing hospital readmissions. So those are the most up-to-date customer results that we've had. We are obviously working on supporting with data current clients that we have, and should be having another two sets of data coming out within the next month that we can obviously pass on to everybody. But the point being that we definitely are a database driven company. We built the company with the faith and knowing the history that remote monitoring has had in not just home health, but in healthcare in general. But now that we focused really on home health and trying to develop best practices, I think we're going to see a significant decrease in not just the readmissions, but also with helping with nursing visits and also patient satisfaction scores as well. So that's kind of our focus going forward as far as seeing what remote patient monitoring can do and some of the outcomes that we have. And then wrapping things up, I'll basically just kind of go over some of the innovative things that we, I didn't even know some of these clients were actually doing these things. And in the past 5 weeks, we've been having these telehealth conference calls with our current clients where different agencies from different parts of the country, kind of share their success stories, best practices, how they use our system, and it's been really interesting. I put Adirondack Health here at the top because one of the approaches that, one of the many approaches that's kind of come out of this partnership is a bariatric post-acute program where the surgeons want to monitor the patients for 2 weeks post-op after they have their surgery, and it will obviously include their daily symptom questionnaire that's specifically that they want to ask. They'll be able to do wound imaging with it, and basically be able to monitor these patients and kind of keep track of them remotely for just that 2 week period, and hopefully prevent any either adverse outcomes, readmissions, ER visits, but also that they don't have to come in the office if something comes up that they can possibly video call. Hello? Oh, sorry, I thought there was a question. So that's one example. Another innovative example, physical therapist monitoring total joint patients at the VNA Home Care in Syracuse. So they have this decentralized approach, actually, where they don't have a telehealth nurse, but they're using the physical therapist in the field, using mobile apps and the software to actually be able to monitor the total joint patients remotely, to kind of see their daily symptom questionnaire, possibly video conference on days that they either feel they don't need a visit or that they refuse one because they're having a bad day, whatever it might be. So that was an innovative approach because, again, it's not a centralized approach. There's not specifically a telehealth nurse doing it. It's the physical therapists that are doing it. Mission ACO in Asheville, North Carolina. So they're using us. They first rolled out using HRS for their PACE program, not for their home health. And they wanted to specifically address their diabetic patients because they were having a lot of issues with their, as far as behavioral health, with depression and readmission and lack of compliance with diabetic patients that were in the PACE program. So they have a really interesting, questionnaire talking about sleep hygiene and, dealing with stress and, again, just a different population that's not your typical, which is most agencies, start with CHF, but it's always interesting to see how, current clients are, really need to utilize the system based on the needs of the populations that they're serving. Cornerstone VNA in New Hampshire. So they've had a very successful program. I think I actually skipped over their result. They had a, is it on here? Yep, they had a 60% reduction in CHF readmissions. Had gotten that down to 4.8%, 6% for their COPD population. So for the patients that were on remote monitoring. But what they're doing that's pretty interesting now is, in conjunction, they have a relationship with the local paramedics in the area, and for patients that aren't on home health, that either refuse it, don't qualify, or have been discharged, but are still being kind of at high risk for ER or readmission, they are working in conjunction with paramedics to monitor the patients, and if need be, since they're not on home health, if they find that there's something that could possibly be an alarm for them to go in to the ER, to the hospital, they could notify the paramedics to do a pop-in visit. So again, innovative approach using our system, but using different personnel and relationships in the area for kind of saving costs, helping patients that aren't currently on home health. And then the last two, long-term remote patient monitoring for two different avenues, really. So one is something similar to what I just mentioned, WellCare in North Carolina. They've been monitoring patients that are discharged from traditional home health for months. And again, we didn't know, I would say three out of these programs we didn't know about until the past 5 or 6 weeks. But they've been monitoring patients for up to 9 months that have been discharged out from traditional home health. And primarily because the doctors were saying, this is working for them. The patients really want it. Can you just keep them on there? And it helped, as far as they're not getting reimbursed for it, but they're keeping the patients out of the hospital, and the referral systems that are generating or sending patients to the home health are obviously continuing to do so, and happy with the program and happy with the agency for doing so. So it's kind of a built-in relationship between the providers and the home health agency and the patient that, this is working for a specific amount of patients, and we're just going to keep them on there and just make it work. So that's a interesting approach that, and we talked to them about private pay, and they've had some limited success with that, but hopefully growing the program on that side as well. And then the last one, long-term remote patient monitoring and gain sharing. So Basis Internal Medicine is a physician group out in Idaho, and they've worked out a relationship between the largest hospital system there and one of the payers, the primary payer in the area, to basically to give them a percentage of the money that they save the hospital system, the payers for any readmissions that they prevent. So right now the program is out of pocket. The patients are being monitored by not a home health agency, but a telehealth nursing company, and that information is being fed into the physician's office, and they can do virtual visits that way. And whatever money, again, that they save from decreasing those readmissions will be going into the physician's group. So those are just some examples, again, of different ways as far as remote patient monitoring that are, you know, maybe not necessarily as traditional, but are, you know, pretty interesting. And as far as results, we're going to follow up and hopefully release some data on at least some of these to show how it works. So I guess, you know, I'll throw it over to you, Katie, but are there any questions from anybody else out there?
Yes, I have a couple of questions. One question comes from Peter Kaplan. He was curious if you could provide the cost per patient for the monitoring service and what the average cost savings are in readmission reduction.
Sure. So as far, we don't necessarily have like a per patient model cost. It's really a per unit cost. So we provide the software and hardware for the patient to be monitored, and depending on whether it's a lease or a purchase option, I mean, I have no problem talking about this stuff. It can be around $112 a month. That would include all of the, you know, equipment, all of the data because it runs on the 4G network, all of the customer support. But then with the purchase model, it would be about $64 after you purchase the equipment. So again, we don't have a per patient model right now. Just that is our unit price, which can be used for one patient or multiple patients depending on how you use it. As far as the second question, the savings, you know, really does depend on the diagnosis and the, you know, the region, but typically, you know, saving on a readmission from the data that we've looked at, it's $15,000 per patient if you can save a hospital readmission. So that's a significant amount of money. And again, looking at that study or that information released by First Health for 220 patients, $2 million, you know, the numbers work out similarly to that.
Wonderful, thank you. Next question is, how does HRS define patient adherence?
Sure. So patient adherence from the data and the real-time information that you can view is every single day is a patient taking their blood pressure, pulse ox, weight, temperature, whatever it might be for that biometric, as well as a daily symptom survey. So I'll just, you know what, I have an example here of the population report that we generate. And sorry, having a little trouble scrolling with that sidebar there. But so for example here, CHF patients, for 204 patients that were on this 6-month period, if I come down here to readmission or adherence, blood pressure session adherence, 85%, that means that for those 204 patients, that 85% of the time they took their blood pressure every single day.
Wonderful. I have a couple more questions. Does the patient need to subscribe to an internet service?
So with our platform, no. The tablets that we use that come preloaded with our software, they run on both AT&T and Verizon. So they can just be turned on and handed to a patient and they're ready to go. They can hook up to a Wi-Fi if needed. If there's a connectivity issue, we also have the possibility of a landline, and but there would be no video conferencing and it wouldn't be real-time data. And we've also worked on hotspots in other parts of the country. For example, Wisconsin, they have U.S. Cellular and I always forget the second name of the other company. But those are in the rural parts there, that is where the service is. And so we've worked in conjunction with our partner there to develop hotspots with that company to work with the tablet. So the patient does not need any Wi-Fi or to subscribe to any cellular service of their own.
Okay. Next up, what are the implications of lower utilization and compliance? Or maybe I should phrase that. She kind of rephrased it two ways. So implications with lower utilization and compliance, or what are the implications of reduced utilization in the home care model from a compliance perspective, given that the plan of care is prescribed by the doctor?
So Okay, I think I got to break down the question a little bit. I'm guessing that as far as adherence, at least from my understanding of the question, it's, you know, obviously the less adherent a patient is to actually taking their biometrics every day, the more likely they are to have adverse outcomes, increased weight, increased readmissions or ER visits. And so being able to increase that adherence level and see what's actually going on with the patients with their symptoms as well as their biometrics allows the patients, as well as obviously the nurses doing the monitoring, to see what the real story is, and then identifying trends as well to combat with changes in medications or changes in diet or whatever it might be.
Okay. This person has a couple of other questions, so bear with me. Is there any indication on whether telehealth is more effective on short-term versus long-term patients in your home care remote monitoring perspective?
Right, that's a good question. I don't think the model. I guess the problem with the data gathering on that side is that for the most part, and not across the board, but for the most part, most agencies will monitor a patient for like a 30 to 35 day period, versus some agencies which tend to be either hospital-based or work with an ACO will sometimes monitor for 60 to 90 days. So I think the data there is less prevalent, you know, for the 60, 90-day period than it is for the 30-day. So it's harder to comment because, you know, again, I think the data gathering and looking at the readmission information, it just really does tend to stay focused on the 30-day because that's the prevalent time frame for monitoring. So, and I've done, you know, as far as myself looking at the research too, I was looking specifically at adherence levels post 30 days. I was doing this a few months ago when Catholic Health had done that, and I wanted some baseline kind of information, which I couldn't find, unfortunately. So, and the reason I'm bringing that up is, again, there's kind of a lack of data as far as the post 30-day readmission or monitoring for patient readmission. But it is something we're definitely working on. We're actually working on, there's a Medicaid-based community program that we work with in North Carolina that does monitor for 90 days. And we should be releasing that information within the next, I would say, 3 to 4 weeks. So we'll have some, you know, small data, but not large enough to really, you know, talk too much about.
Wonderful, thank you. Next question, are there any incentives provided to increase patient adherence?
Yeah, stay out of the hospital. Or no. I wish there was something like a Modell's gift card or something that we could provide, but incentives, like we have looked at, you know, kind of we've talked about it. It's not anything that's really on the top 2 tiers of our development list, but we have looked at gamification type of incentivizations using our platform. You know, our platform is completely locked down. There's no access to anything else on the tablet. And there's a few reasons for that, but one of them really is to make sure that the patient just focuses on doing what they need to do with the software. But, you know, we see the value in kind of incentivizing that somehow. So we're looking into that. I wouldn't say that's definitely a top tier as far as development of what we're looking to do.
Okay, and then there was one more. Let me just find it. Kind of in line with that last question, how do organizations or even health recovery solutions obtain such high adherence? Is there any sort of best practice for that, or common themes that you see among organizations that do have such high adherence?
Yeah, and that's why we've been having those calls lately, and it's been really, I've been moderating them, so it's been really, it's just been great. I mean, telehealth nurses, you know, it's not like, it's kind of like, my background is I'm a home care PT. So like I know when I'm in the field, it's just me kind of solo, unless I run into a home health aide. But, you know, we case conference on the phone, but you're kind of just this person out alone. And telehealth nurses tend to be the same in a way, except they're not out in the home, they're in the office, and they're, you know, really just busting their butts, trying to, you know, review all these patients, contact them, contact the doctor, contact the nurse in the field. So getting 3 telehealth nurses on the phone and talk to each other it was just great for them, but good for us, obviously, as far as best practice. And some of the things that we came up with or heard was, one, at least with our software, that text messaging feature was huge. We didn't think that agencies were really using it that much, to be honest with you. But now more and more agencies, I think, as telehealth nurses get used to new things, new features in remote patient monitoring, they just start to use it. It's just like the patients. And once the patients kind of get used to it, then they start using it. So the text part has been huge for the adherence rate. That really was something surprising that we got out of the calls. We had heard that before, but we hear more people doing it now. The other part was, we had preliminary information on like patient to nurse ratio as far as remote patient monitoring. We kind of in the past were talking about 100 patients to 1 telehealth nurse being like the max before quality really drops off and the ability to follow patients and actually call them, took a dip. So what we found, though, is with the video conferencing part, that the video conferencing takes longer. It takes longer to either set up, or patients are just on the phone more because you can visually see them and you're getting more out of them. You can do inhaler training. You can see if they have their cannula on. There's just more to do. So that takes longer. And since it does, that ratio, what we found, this is, again, preliminary information, it drops from that 100 to 1 to like 85 to 1 to really be effective throughout the day. And that's really like the max that we're talking about. And then the last thing I would say, too, is that the agencies that really do well as far as adherence levels, I think I've found from talking to them 2 things. One, they tend to be agencies or systems that have 2 telehealth nurses in place kind of working in conjunction. And I think part of that is like you kind of have a team member to count on, right? Like when you're out or you're really busy or whatever it might be, and the ratio is smaller then you can focus on really contacting the nurse, because it takes so much time to monitor the patients and then reach out to them and then look at the nurse's schedule and then go back and talk to the nurse or talk to the patient and then try to figure out what's going to be best. So that's something, again, kind of preliminary that I found. The other one is there always has to be a champion, right? And this doesn't go for remote patient monitoring, this goes for anything. So the programs that had somebody really in charge of the program that I could or that our account managers could reach out to and kind of follow up with, as well as the telehealth nurses, whether it's a telehealth nurse themselves sometimes or an administrator, the ones that had a real champion in place who was responsible for taking ownership as well as creating data that we could follow up with and kind of talk about, because we do quarterly assessments as well. Those tend to do better with adherence rates as one of the measures.
Wonderful, thank you. I don't see any more questions, but that was a really informative Q&A session, so I appreciate you hanging on while we worked through those. And I can certainly agree with you that having a point person for each organization who's really a champion of utilization and adherence and working with patients is very, very important. And it's interesting to see the innovative care program that you've highlighted using your platform, because I think many organizations tend to think that remote patient monitoring is only for post-discharge. But as you can see, there are a number of organizations, even in New York State, that are using this for bariatric patients, diabetic patients, long-term care, physical therapy. So there's various modalities that remote patient monitoring can be used for outside of what's normal. So thank you, Rich, for your informative presentation. If you're amenable, I'll send your contact information out to the group so they can reach out to you for further questions or to find time to talk more about your platform.
Oh yeah, no problem. Thanks for having me, Katie. And I hope you can tell that I like talking about this stuff, and it's always good to get an audience to do so.
Sure. All right, guys. So the last agenda item is more so Corey and myself. I don't know if anybody can see in the handout section, we've uploaded, or someone has uploaded, the telepsychiatry contracting guidance from OMH. So thank you to whoever sent that out there. I did get an email from Sarah Osborne from Oasis. She wasn't able to join us to speak, but she did give me a brief update that their regulations are still moving through the promulgation process, but they are accepting applications from providers on a demonstration program basis. As of this date, they don't have any active implementations, but do have several applications. If anyone on the line is an Article 32 clinic and wants more information, reach out to me, and I can connect you with Sarah. So Corey, I'll let you start with any updates on your end. I know I have a couple of updates, brief updates for the group, so just hang tight for about 5-10 more minutes, and then we'll do some Q&A after if anybody has any outstanding questions.
Thanks, Katie. So I guess from our side, our biggest project right now, our newest project, is the digital retinopathy. We've got some funding from potential funding from one of our payers here, as well as some state funds. And what we're going to try and do is put a camera in each one of the primary care offices and capture the patients where they are, get that image over to an ophthalmologist, get it read, and then a recommendation back to the primary care for discussing treatment plans with the patients. We see very low scores on closing the loop on digital retinopathy screening. So hopefully those will not only raise those quality scores, but potentially could prevent blindness in diabetics. That obviously, you know, it's a terrible thing, and hopefully preventable with early interventions. So that should be, upon approval, be kicking off here in the next couple months. And of course, you've heard before on many of the calls that we're seeing pretty much exponential growth in the volume of telemedicine visits. So we're happy to see that happening, especially as our regions pursue value-based purchasing, which is predicated on efficient and high-quality care, shared savings, even risk contracts with the payers and partnerships. So when all of that comes to fruition, telemedicine, I believe, will be a key key method of reducing the overall cost of complications because we're providing that access to care early on, preventing some of the exacerbations of the chronic diseases. Very excited. Like I said, this is my first meeting, so it's nice to meet or talk to everyone. And that's the update from our side.
Wonderful. So I have a few quick updates as well as questions to pose to the group, and I would appreciate any feedback that anyone can give me. If you want to give feedback on this meeting, raise your hand or ask me a question, and I will unmute your line. So my first update is an idea that came to fruition a couple of weeks ago, and it's about spoken hub needs. So as I get out there and I meet with partners, I hear, you know, I need teledermatology, but I can't find providers, or I need behavioral health and I can't find providers. And then on the flip side, I hear of behavioral health providers saying they have room to provide telemedicine. So I'm thinking of creating almost a job posting board of sorts on the telehealthny.org website, where spoke sites who are in need of certain specialties and providers to provide said specialty services can post on there or email me what their needs are. And then providers, hub sites who are willing to provide those services can connect the dots. So if anyone on this call has any needs in their own organization, wants to explore teledermatology or diabetic retinopathy or behavioral health or pulmonology, email me and I can collect those responses and create a subsection of our website to put that out there. On the flip side, if you have any providers in your organizations who perhaps have the room to provide a few hours a week of telemedicine services in their specialty, please let me know. We are obviously in dire need of behavioral health providers. I'm hearing pulmonology and dermatology quite frequently. So any anyone who has any knowledge of either of those things I just mentioned, Spoken Hub needs, please let me know so I can start creating what this is going to look like. Next up is an update on the North Country Telemedicine Conference. I would say most of you on this call have seen the invite to this point. Just to remind you, it is Thursday, November 2nd at the Crown Plaza Resort in Lake Placid, New York. Beautiful location. It's a one-day conference from 8 a.m. to about 4:30. We have all of our speakers lined up, so to give you an idea, Dr. Irina Gelman of Fulton County Public Health is going to be our keynote speaker this year. She's done a TED Talk recently on telemedicine, very dynamic individual and doing great things in Fulton and Montgomery counties. We have some breakout sessions from Adaptive Telehealth, United Concierge Medicine, Dr. Julie Lynn from UVM Health Network, and a panel of some folks from Essex County Public Health and Adirondack Health. And we are having Elizabeth Zakari from HCR Home Care start our afternoon off. And to round out the day, we are doing a panel of folks from DOH and OMH. I believe so far Ray Ann is going to be on the panel, Keith McCarthy from OMH, Michael Vitale. We have some folks that are going to speak to the update of the state of telehealth in New York State from a regulation perspective and legislation perspective, so that will be really exciting. I'm hoping that everyone on this call will join us. We have some exciting vendors coming. There will be breakfast and lunch and breaks provided. So I'll make sure I'll send out the link to register for that in my follow-up email with meeting notes today. Last but not least, I am just checking one thing quick. I think we had a follow-up question. Okie dokie. Last but not least, and this may be a DOH question, I'm not entirely sure, but the New York State Board of Professional Medical Conduct statements on telemedicine is no longer available on their website. I'm not sure if anybody on the line, Ray Ann, it's a government website, and we're not sure if updates or changes will be posted soon. So if anybody has an update on that, either email me or let me know. We're looking to find out more about that. Other than that, I don't have any other updates, and there are no other outstanding questions that I can see. If there are any questions that I did not get to, I apologize. I will answer them personally in a follow-up email. So Corey, if you don't have anything else, I think we'll wrap it up for today.
No, Sandal.
No. Katie, this is you did a great job today. Thank you very much.
Wonderful. Thank you, everybody, for joining us. We will, of course, be doing this again next month, so look out for that invite. The Telehealth Learning Collaborative is the third Monday of every month from 2 to 3:30, depending on how long it goes. So we wrapped up earlier today. I gave you a half hour of your life back. You can thank me later. All right, have a great